when we talk about dental aesthetics, let's talk about some of the basics about tooth size. We'll speak about individual proportion, and we'll talk about shape. Let's go through some clinical examples. Okay, so this is Jennifer. The mother's not very happy because the incisal edges are not really lined up. Obviously, that's bracket placement. All right, but this is how she comes in. And she's missing, congenitally missing tooth number 1, 2. Okay. So she's congenitally missing tooth number 1, 2. The orthodontist just put a big tooth in there and just started to move the teeth around. She has a size, individual proportion, and aesthetic issues. Okay, and if you look at the patient's occlusion, you could see that there's no really anterior coupling at all. Okay, so she comes in and we start to discuss, some different aspects. The orthodontist is trying to provide space. I think a lot of orthodontists know that surgeons need a lot of space when we talk about, spacing for congenitally missing teeth. And when Dennis saw Jennifer, he goes, the patient has too much space. I have plenty of space to put an implant in. She's actually only 15 years old, so we're not going to place an implant now. We're going to wait until she's fully grown. And but we want to set up her case properly. Okay. But he said, the problem here is that there's too much space, and he would rather get the teeth in the right position, and then it would help him with implant selection later on as far as dimension. Okay. So the patient's not happy. She doesn't have any competency of the anterior teeth. She's only congenitally missing 1 tooth. It's the maxillary right lateral incisor. The question is, are her other teeth the right size or not? That's really the question. So, she has her lower anterior teeth. They're not worn, and we can go through our algorithm, correct? And our algorithm will conform to the Bolton. Okay, so she has her lower incisor. It's not worn. We're going to measure the width. It's X. Okay, we add X plus 3 to our upper, and we get our Y value, and now we're back to our algorithm like this. So her lower central was, believe it or not, the mean average. So these are the numbers that should be for her other remaining teeth, and it should conform to Bolton. What was very interesting to note is that obviously the right lateral incisor was too large, so I reshaped it to the correct width and length. I could use the proportion gauge for that. Her left central incisor, tooth number 2-1, was too wide, so we actually did a little bit of enamel recontouring of the tooth. We just used some discs and reshaped it. It was actually too wide in width. And the right central incisor was actually too narrow, so we actually did a little bit of bonding to the distal of the lateral incisor, the central incisor is actually too narrow. So obviously the right lateral was too big, we made it small. The left central was too large, and the right central was too narrow. So out of the 6 maxillary anterior teeth, 3 of them had to be reshaped to the orthodontist. So this is the key. If I get the teeth the right size, then all I have to do is tell Mark Hockman, the orthodontist, Mark, move the teeth, because now I have them the right size. And that was easy for the orthodontist. If you get the teeth the right size, now say that you have crowding, you may ask the orthodontist decompensate the teeth, so I either could reshape them or I could add to them or whatever you need. So the orthodontist may have to do some treatment prior to you resizing the teeth if there's significant crowding to decompensate. But at some point in time, the restorative dentist is going to have to be involved to try to get the teeth the right size to then allow the orthodontist to move the teeth. It's just that simple. And that's how I would sort of try to sequence these type of patients. And then once her case is set up, the dentist goes, okay, now I know how much space I have, and now I can figure out what width of an implant I should use. Now, since she wasn't fully an adult or fully grown at that time, we could have a discussion about how do you determine when a patient is fully grown for treatment. I think that's a question I would like to have a discussion about, because I don't know all the answers, but we have a very simple way of approaching it. But let's have a discussion, because I think that comes up all the time. What is the timing of implant placement for patients who are not, quote, adults or fully grown. Okay, so we did sort of this transitional Maryland bridge for her because we just wanted to hold her over. Again, she was only like 15 years old at the time, so we wanted to wait till she was maybe late teens, early 20s before doing anything more definitive for her. So we just did sort of these type of Maryland bridges. Now we can probably obviously do this through digital, but this was the old school way of doing that. And of course, we all know that highly polycystic zirconia is very kind to the opposing dentition. Hammerly did some of those studies, and we know that you have to use a primer, a zirconia primer. So we were able to then go from the left, which means that she didn't have any competency in regards to occlusion. She didn't have the right size teeth that were in the wrong place. You could see that my bonding on the distal of the right central incisor could obviously be a little bit better, but now we have the teeth in the proper position. So we've done the correct tooth size analysis, the correct proportion, and now all the orthodontist has to do is move the teeth. And that we find is a very simple solution. Now, she only had one tooth that was missing, congenitally missing. That was her chief complaint. But you could see that even for a single lateral that was missing, that it was much more complicated than what she presented with. Understood? When she became an adult, we did see her, and Dennis was able to place an implant, as seen over here. So he placed the implant. We can talk more about implants later on in this regard, but it's just showing that he was able to place the implant and augment the site at the same time. Once that area had healed, we can go back and then recontour our provisional restoration to contour and do what's called non-surgical tissue sculpting with our provisional restoration. We made the provisional lighter in shade because she was going to bleach or whiten her teeth. The problem is that we had to sort of guesstimate because she was actually going to law school. So when I saw her, she was leaving for law school. And then when she came back, we would have the final crown ready. But the problem is we gave her bleaching trays and we assumed that she would have a 2-shade change. That's sort of the average from the literature. So she would bleach her teeth. But we made the impression, and we were then able to make her a crown. And then when she came back, she had whitened her teeth. So we're sort of guesstimating. It wasn't the most precise way of doing it, but that's because she has been going to school abroad or not in New York. So we're able to at least anticipate. And hopefully I told her she'll get some rebounding of the whitening so that the color will match a little bit better in the end. Okay, so that's how we sort of sequenced this one patient, congenitally missing lateral incisor.